Let's dive straight into pulmonary, embolic, and environmental emergencies. Here are the 6 clinical areas we're tackling today. The post-exposure dyspnea split, embolic emergencies including air and fat, ARDS and lung protective ventilation, dyshemoglobinemias and cellular hypoxia, high altitude and decompression sickness, and finally, drowning and hyperventilation syndrome. Section 1. The post-exposure dyspnea split. When you're hit with a sudden respiratory distress question, your entire diagnostic tree branches on the exposure history. Was there a procedure leading to sudden collapse? Think air embolism. A long bone fracture 24 to 72 hours ago? That's your fat embolism. Smoke inhalation opens up a triad: carbon monoxide, cyanide, or thermal injury. Oxidizing drugs like dapsone point straight to methemoglobinemia. Travel history is huge. High altitude or scuba diving splits you right into altitude illness or decompression sickness. Submersion injuries give you drowning physiology. And if you've strictly ruled out all cardiopulmonary causes, then you land on exclusionary hyperventilation. Locking in the timeline and exposure is exactly how you anchor your diagnosis. Section 2. Embolic emergencies, air and fat. You need to sharply separate venous and arterial air embolisms. Venous air embolisms happen after central line manipulation, neurosurgery, trauma, or positive pressure barotrauma. Small bubbles, they just diffuse. But large volumes, they lodge right in the right ventricle, blocking the outflow tract. This triggers sudden respiratory distress, severe hypoxemia, obstructive shock, and even cardiac arrest. On the flip side, arterial air embolisms occur when bubbles bypass that pulmonary filter, usually through a right-to-left shunt like a PFO or overwhelming barotrauma. The result? Direct downstream ischemia, hitting the patient with a sudden stroke or MI. If you suspect a venous air embolism, your immediate next best step is high-flow, 100% oxygen, and the left lateral decubitus position. Turning the patient on their left side physically traps the air pocket on the lateral wall of the right ventricle. It stops the air from migrating and blocking the RV outflow tract, stabilizing hemodynamics while that air reabsorbs. Now, if it's an arterial air embolism or a severe venous case, you're going to need hyperbaric oxygen therapy if it's available. Moving to fat embolism syndrome. The exam loves testing this exact timeline. It classically hits 24 to 72 hours after a long bone or pelvic fracture, an orthopedic procedure, pancreatitis, or a sickle cell crisis. Look for the clinical triad: hypoxemic respiratory distress, neurologic dysfunction, and a petechial rash on the head, trunk, or subconjunctiva. Be careful, though, because that rash shows up in less than half of cases. When it is there, it's highly specific. The diagnosis is purely clinical. Prevention relies completely on early fracture immobilization, and once it happens, your treatment is strictly supportive care. Section 3. ARDS and lung protective ventilation. For ARDS, the radiographic hallmark is new bilateral alveolar opacities popping up within 1 week of an inciting clinical insult. Whether the lung injury is direct or indirect, it causes an inflammatory alveolar capillary leak, flooding the alveoli and tanking lung compliance. The absolute key here is that this edema cannot be explained by heart failure or volume overload. Pathophysiologically, you're dealing with a severe VQ mismatch and intrapulmonary shunting. This causes profound hypoxemia that stubbornly refuses to correct with supplemental oxygen. You have to know the strict lung protective ventilation algorithm for ARDS. First, confirm the hypoxemia indicator, a PO2/FiO2 ratio of 300 or less. Second, set mechanical ventilation with a low tidal volume, specifically 6 milliliters per kilogram of ideal body weight. This prevents alveolar overdistension, and permissive hypercapnia is perfectly acceptable here. Third, keep that plateau pressure at 30 centimeters of water or less. Ensure adequate PEEP. Use the lowest feasible FiO2, keep fluid management conservative, and for severe cases, prone positioning is your go-to for distributing ventilation to dependent lung regions. Section 4. Dyshemoglobinemias and cellular hypoxia. Let's talk oxygenation traps. Methemoglobinemia gives you cyanosis and chocolate brown blood after exposure to oxidizing agents. Think dapsone or topical anesthetics. The classic trap is the pulse oximetry gap. Standard pulse ox will read around 85%, but the ABG-PaO2 looks completely normal because dissolved oxygen isn't affected. Treat symptomatic cases with methylene blue, but watch out, use extreme caution if the patient has G6PD deficiency. Carbon monoxide poisoning from smoke or enclosed fires is the opposite trap. The pulse ox looks entirely normal because it literally can't distinguish carboxyhemoglobin from oxyhemoglobin. Confirm with an ABG carboxyhemoglobin level and treat with 100% high-flow oxygen. You'll escalate to hyperbaric oxygen for severe cases like seizures, myocardial ischemia, or high exposures in pregnancy. Now, cyanide toxicity.
This poison completely blocks oxidative phosphorylation at the electron transport chain, forcing cells into a lethal anaerobic state. You'll see a severe elevated anion gap metabolic acidosis with sky-high lactic acid, circulatory collapse, and coma. Watch for this after enclosed structure fires involving burning plastics, mining exposures, or prolonged nitroprusside infusions. Because cyanide is rapidly lethal, you absolutely do not wait for labs. The definitive next best step is empiric treatment with hydroxycobalamin to bind the cyanide directly, alongside supportive care.
Section 5. High altitude and decompression. Altitude illnesses all stem from a reduced partial pressure of oxygen. Acute mountain sickness, or AMS, brings on headache, nausea, and fatigue. High-altitude cerebral edema, HAC, progresses to confusion and ataxia due to increased cerebral blood flow. High-altitude pulmonary edema, HAP, involves uneven hypoxic vasoconstriction leading to dyspnea, cough, and hypoxemia. For all three conditions, immediate descent is the definitive mandatory treatment. Everyone gets oxygen. Acetazolamide helps with AMS, and you'll reach for dexamethasone if it escalates to HAC. Decompression sickness happens when a rapid ascent from deep environments causes a sudden drop in ambient pressure, forming nitrogen gas bubbles right inside the body. Type 1, known as the bends, gives you mild musculoskeletal pain, itching, and skin mottling. Type 2 is much more severe. You get neurologic deficits called the staggers, or severe pulmonary distress and localized ischemia known as the chokes. Immediate management here requires 100% oxygen, IV fluids, and hyperbaric oxygen therapy to shrink those bubbles and restore tissue perfusion. Section 6. Drowning and hyperventilation syndrome. Drowning causes massive direct alveolar injury. Aspirating contaminants washes out surfactant, leading to atelectasis and permeability edema, which sets up a massive risk for ARDS. Because profound hypoxemia is the primary and most immediate insult, your very first step must prioritize rescue breaths. Get the oxygen in. After that, remove wet clothing to stop hypothermia, transport to the ED, and hook them up to continuous cardiopulmonary monitors. A key point, even completely asymptomatic patients must be observed for at least 8 hours to evaluate for delayed pulmonary edema and ARDS. Finally, hyperventilation syndrome. This is strictly a diagnosis of exclusion. You absolutely must rule out pulmonary embolism, pneumothorax, and other cardiopulmonary emergencies first. It's driven by respiratory alkalosis, which drops ionized calcium, causing paresthesias, lightheadedness, headache, and carpopedal spasm. Pay close attention here. The standard of care has shifted. Breathing into a paper bag is no longer the next best step. Instead, you treat with breathing retraining and reassurance. If symptoms are severe and persistent, a low-dose, short-acting benzodiazepine is your acceptable second-line option.